Well, we have transited from bare metal stents to drug-eluting stents, and those of you who are more than 20, 25 years in this business, they have seen how bare metal stents replaced balloon angioplasty by 1994. Although the stents, bare metal stents made angioplasty safer, but there were lots of limitations which became apparent soon. And restenosis was the real Achilles heel, especially in small vessels, diabetics, multivessel disease. And drug-eluting stents seemed to be the most practical solution. In between, we had an era of brachytherapy and many other lasers and all that, which all did not work or were impractical. So drug-eluting stents have replaced bare metal stents. And this is the first study which came in 2002. Unbelievable. In fact, Patrick Sarai's made a comment that, "Don't pinch me, let me sleep." 0% restenosis, 0% TLR, 0% thrombosis, and with aspirin and clopidogrel only for 2 months. Unbelievable, but that's what the fact was. They were simple lesions. And then there was a revolution in interventional cardiology from the days of stress, which showed that bare metal stents were better than plain balloon, came the ravel which showed that drug-eluting stent was clearly superior to bare metal stent. And then came two big studies from two sides of the Atlantic. One was serious with CIPHER, Texas, both of them, and both of them showed that both the stents worked. One was a very potent anti-inflammatory, anti-cancer drug, paclitaxel, and the other was a drug, the Limus drug, which is still with us, CIPHER, and both of them seem to be working quite well. And this is a meta-analysis of the trials because which one was better was a big debate, and then clearly it showed that major adverse cardiac events in a number of trials favored CIPHER. The late loss, which was a surrogate endpoint of drug-eluting stent, was clearly lower with CIPHER. And sirolimus-eluting drug-eluting stent therefore seemed to be superior to paclitaxel-eluting stents. But there was a category. What about diabetic patients? Still, people were propagating that in diabetics, paclitaxel works much better. And our group was the first group which did a very prospective study and laid paclitaxel-eluting stent to rest. And this is in diabetics comparing Taxus with everolimus-eluting stent. And you could see that the target vessel failure rate at 1 year was clearly significantly in favor of the everolimus-eluting stent. And if you look at the components of target vessel failure, there was no difference in death, but what was different was target vessel myocardial infarction, clearly much, much, much higher with the Taxus, and this was stent thrombosis, which was a big problem with the Taxus stent. And then 2006 came a big furor that drug-eluting stents are dangerous. And meta-analysis of all the studies comparing CIPHER with bare metal stents and Taxus with bare metal stents both showed there was a significant increase in death and Q-wave myocardial infarction, which prompted Salim Yusuf to say that drug-eluting stents are like ticking bombs in the heart, and they can explode any time. Beware of it. And then came a new era. There was a lot of discussion, and newer drugs, eluting stents, a newer generation came, and safer polymers, because the previous polymers were not very good, they were not very user-friendly, they used to get into thrombosis. Renu Virmani showed in a number of studies the thrombogenicity of those polymers. Came the biodegradable polymers, or some of them without a polymer, and then the drugs which remained with us and are with us today are the Limus drugs. Sirolimus, everolimus, zotrelimus, biolimus, all of them are there. And then the newer generation, drug-eluting stents versus drug-eluting stent randomized studies, comparing zotrelimus with everolimus and biolimus with everolimus, all were equivalent, indicating that new generation drug-eluting stents with better polymers, safer polymers, whether they were durable like in the Zions, or whether they were biodegradable, as in many other stents, were equivalent in efficacy and safety. And then came an era when we were overawed by bioabsorbable or bioresorbable vascular scaffold, and a very good concept that nothing will remain in the vessel after a couple of years, nothing like it. And this is, the absorb, which came as a very important revolution in 2015-16, that, you leave a vessel like this, pristine vessel after 2 years. And came the number of trials, absorb 2, 3, and absorb 3 was the trial which showed that there was a problem initially in the smaller vessels, significant stent thrombosis, although that was not the same in the bigger vessels. And came the IDA trial, which again showed stent thrombosis to be a big problem in the bioabsorbable stents. And then there was a twofold increase in device-oriented clinical events, marked increase in target vessel myocardial infarction, 6 stent thrombosis versus 0 in the Zions group. And trial was prematurely stopped because of safety lesions. So scaffold and its problems, follow-up studies have indicated a concerning issue of stent thrombosis, despite continuing 2 antiplatelet drugs, and if you had to use it, you have to continue these 2 drugs forever. Strut thickness was a major issue. Special techniques were recommended that you must do it, all of them under intravascular imaging. And finally, Abbott withdrew the bioabsorbable vascular scaffold, the absorb stent, which was doing, lot of, making a lot of noise. Then came the new generation BVS, and one of the Indian companies, the Merrill, brought in a 100 micron stent as compared to 116, and it's again being used, but I must say that the data is very limited and it is not enough to change our practice. So for the time being, I think they have been put to rest. Then came the era of ultra-thin strut thickness drug-eluting stents, and a number of them. Bioflow from Biotronics were the leaders, Merrill, and then in Indian companies, Sajan and Medical Technology brought in Supraflex, stents up to 60 microns strut thickness, and we had equivalence data from several studies with second-generation stents like Zions, Promus, and Endeavor, and data in several clinical scenarios was there, like in Bioflow 5, which is a stent from Biotronics in myocardial infarction patients. Very clearly, Orsiro versus Zions, you can see that target lesion failure, Orsiro did better, target vessel myocardial infarctions were lower. And if you look at the combined data, which was published by Sripal Bangalore in 2018, the newer generation ultra-thin strut drug-eluting stents versus the older generation, like the Zions, there was lower TLR, lower myocardial infarction, lower stent thrombosis with no mortality difference, indicating that they were not only easier to deploy, but also the results resulted in better outcomes. And that was only 1 year follow-up. Came another study by Madhavan, 2 years for 2.5 years follow-up, showing that ultra-thin strut drug-eluting stents reduce the risk of TLF, driven by lower ischemia-detected TLR as compared to conventional study, once again indicating that even at longer term, these ultra-thin stents are better. The present-day ultra-thin strut thickness stents, we have enough data. They are preferred choice in most clinical situations. Adjunct use of intravascular imaging should make the results even better, and longer-term results with these biodegradable polymer stents need to be carefully looked at. And then I talk about 2 studies in which we have participated. One was the TALENT study, in which the Supraflex stent, 60 micron stent, was compared against Zions, and it was shown that Supraflex was non-inferior to Zions for device-oriented composite clinical endpoints. And this brings me to our prestigious study, the Tuxedo 2, in which we are comparing Supraflex screws, which is 60 microns, with Zions in the very complex subset of patients of diabetics with multivessel disease, where 15% of patients have double vessel disease and 85% have triple vessel disease. The idea is to compare the two stents with guideline-directed optimal medical therapy in a complex subset of patients. The trial will also answer whether a biodegradable polymer-coated stent with very low stress thickness is an attractive option for PCI in diabetic patients. And in addition, we're also looking at whether ticagrelor or prasugrel, which one is better or they're equivalent in terms of efficacy and bleeding. And finally, we're going to compare against this very important question, whether the results of FREEDOM trial, which had shown that surgery is clearly superior in diabetics with multivessel disease, would the results have been different in the current era of safer and more efficacious stents and modern medical therapy? So, are we done? We have progressed significantly from the days of first-generation drug-eluting stents to durable polymer, biodegradable polymer, finally ultra-thin strut thickness drug-eluting stents. Time is now ripe for a reappraisal seeking an equivalence with bypass surgery in complex subset of patients, including diabetics, using these ultra-thin, low-thickness drug-eluting stents with safer antiplatelets and guideline-directed medical treatment, which is all has improved over the last, 1 decade or 2 decades. The current generation drug-eluting stent is only one component of this transformation. The journey has many, many facets, and it has to be taken holistically. So thank you very much, and that's what I had to talk about, that we are not through. We are going on, and we have many, many answers in the future. Thank you very much.